What about, let's just wrap us up with just one sentence on maintenance. I think we've all concluded maintenance is good and most people should be on it. The only controversy left, it seems to me, is stopping over time or indefinitely. I mean, I hate the idea you'd put a young patient on this for a decade who might be cured, for example. How are we going to deal with that, Tom?
Well, I think at this ASH, there were a couple presentations on using ixazomib, an oral proteasome inhibitor, as a maintenance-based strategy. There was the HOVON, I think it's 126 study, where they used ixazomib as maintenance in the non-transplant setting, and there really didn't seem to be a benefit of ixazomib maintenance. And then Dr. Demopoulos presented it in a post-transplant setting. So any induction, single autologous transplant, and then ixazomib maintenance for 2 years. And the ixazomib maintenance arm had a PFS of 26 months, and the placebo-based maintenance had a PFS of 21 months. So it was significantly improved, but comparing apples to oranges, and we always do that, unfortunately, compared to lenalidomide, it seemed like it didn't have as much strength as lenalidomide. So if I'm going to use a one-drug maintenance therapy, I'm going to probably use lenalidomide.
Let's get some other opinions about the tourmaline study, which was ixazomib versus placebo. Big phase 3 trial, 4-month improvement PFS at the cost of some toxicity and
I think
price.
my biggest issue with that is that in my definition of maintenance is one of the agents that got you to that response being used to maintain that response. And these patients had other inductions, transplant, and then were started on ixazomib as a new line of therapy, really. Calling it maintenance to me is semantics, but to me that is not maintenance. I do believe in keeping them on, and I generally do go down to a single drug. I try to get patients off steroids. The sooner, the better.
Well, let's assume we get everybody off steroids, but I guess what the question becomes is that since there was some benefit for ixazomib, is ixazomib plus lenalidomide now? Although,
I'm going to correct you. I think it was a 6 months benefit in PFS.
21 to 26.
21 to 26.
That's not fine. The point is
I think the other thing that you were talking about earlier is, and I think Rafa mentioned it as well, is that I'm not sure that 2 years is enough, because in the initial French study of Revlimid, you see people drop off the curve as soon as the drug stopped.
and you saw that in the UK as well.
And we saw it in the UK,
yeah.
and I think we see it here as well. So
But is it forever? I mean, I see
I'm not sure it's forever either. Okay, I agree with that one. But I think that maybe we do need 3 years. I think the other thing, as you said, what this does give us confidence on is that it's tolerable, and if we want to actually add it to Revlimid and have we can argue whether we're now getting into long consolidation or not, but it's certainly a regimen that's oral, tolerable, and you could.
Let's do a little rapid fire here. What about other drugs in maintenance?
Okay, so there's my 4 points on maintenance. Well, that is important. I was not going to mention. Everyone should get maintenance unless there's a compelling reason not to. High risk, combine PI plus lenalidomide. That's what I'm doing, and I use ixazomib for that. I predict
Let me stop you there. Why wouldn't you use that in standard risk as well?
I think the data for standard risk is good enough that I would say it's contingent upon other trials to show me that you can do better with that. But it's a good question. There's no way to rebut that categorically.
I see you trying to, but you.
But here's 2 things more for other drugs. I think we should start preparing for seeing venetoclax for 11-14 maintenance. And the last point, I think MRD will be key in how we manage maintenance. Instead of guessing 2 years, 3 years, you have sustained MRD negative status, then you're okay.
Tom?
I think daratumumab is going to really be the agent that we're going to use, likely together with either pomalidomide, or if they're high risk, or if they have residual disease, or with lenalidomide if they just have standard risk. I think it's going to be a 2-drug with an antibody going forward.
It kind of feels to me that that's where we're heading, that you'll get your remission and then you'll probably have 2 or 3 drug maintenance of some kind of, I mean, I hate to think about the cost, so we're not going to go there, but it's a significant
So it'd be nice to be able to identify which patients need it and which patients need the PI.
And maybe in the next section we'll find ways we can avoid it.